Hi, I'm Kimberly C, and we're here today in a new exploration looking at what we can do prior to people getting end-of-life care. And what Gabby and I have been doing and thinking about the last few weeks is how can we bring something to the public. And Gabby, you and I have been talking a little bit about what to name this, and we're thinking this morning, At the Bedside.
Love it.
So what our goal is bringing experts from this end of life field to this conversation, hoping to answer questions, really difficult questions prior to experiencing any kind of medical event at end of life, and maybe even prior to a serious illness. I think the whole mission of what we're trying to do is really illuminate what death and dying is all about and get people to start having conversations way before the end of life. And I'm really proud to have some of these individuals on this new sort of platform we're calling At the Bedside. And I'd like to introduce them to you. Of course, let me go ahead and introduce Gabby Jimenez. And she is one of my dear friends that we've been working together for the last few months. And she started really becoming a hospice nurse in your 40s. She shares the difficult journey in her book, Soft Landings. And becoming a hospice nurse, it opened her eyes and sort of changed how you plan on you are living and dying, right, Gabby?
Absolutely.
So welcome, Gabby. And she is my sidekick on this new platform. So I'm really fortunate to have you collaborate with me. So thanks for everything you're doing. So, Dr. Gary Pasternak, you are a board-certified internal medicine. You're a hospice and palliative care physician. You've been doing this work for 20 years, supporting those at home going through this process. And you're also the medical director at Mission Hospice in Northern California. Welcome to the show.
Thank you. Glad to be here.
Yeah, it's nice to see you. And of course, not to make her go last, but she is I'm one of her biggest fans. And I think she's been a really mentor and a dear friend to me in the last few years as I've created this podcast, Barbara Karnes. And if you don't know who Barbara Karnes is, then you are not working in this field. She is a leading pioneer when it comes to educating about the dying process at end of life. She's best known for us who have worked in the hospice field, this book, Gone From My Sight. And everybody refers to it as a little blue book, and it really has changed the hospice field. It has been in print since 1985, and you sold just a few, over 30 million books. So welcome to the show, Barbara. It's so nice to hear your voice and see you again.
Oh, I'm really excited about being here. It's a great project we're on, and I'm excited about it.
Yeah, it's really cool that you and Dr. Gary and Gabby were all coming together because, like we said before we started recording, this is not a solo project. It's going to take a collaboration and move through this and create and maintain this innovative field that we all love. So today, what our concentration and what we're going to focus on is really the difficult questions that we're finding at the bedside when patients and families are within an end-of-life care, whether it's doula care, death doulas or hospice care. There's families that are having and asking difficult questions, and it seems to be way too late. But before we get started, Dr. Gary, I really wanted you to help us better understand what the heck is the difference between hospice and palliative care, because I find that many people don't know this. So help us out.
Well, so there's the simple answers, and then there's the sort of more nuanced answers to it. But let me give a stab at the simple ones, because hospice care is probably the easiest to define, because hospice care is really care that's directed toward the last days, weeks, months of living. And it's a movement that started way back in the Middle Ages and even before for caring for the sick and dying, but became, much more extant in our country in the 1970s and 1980s, and it was codified by Medicare. So when most people think about hospice, they're really thinking about the Medicare hospice benefit, but it really is a philosophy of care that's aimed at taking care of the whole patient and family towards the end of life. So it's quite prescribed. And in the Medicare parlance, person has to have a prognosis of less than 6 months of life left to be eligible for hospice. Of course, for younger people, they may have private insurance or no insurance at all, but the philosophy is generally the same. And it's a multi-dimensional team approach to taking care of, all aspects of suffering at the end of life. So it's a much more prescribed kind of a provision for medical and psychosocial care. And in fact, in many situations, it's the best way to get the most intensive medical treatment in the home or a facility where people are. So that's hospice. Many people have the misconception that it's a place to go, and it sometimes is a place to go. Like we have a hospice home, and hospice care can be, provided in facilities, but most patients who are on hospice are taken care of at home. So it's important to remember that, because many people think, I'm going to go on hospice, and you think I have to go somewhere. No, it's primarily provided. Palliative care is a much more difficult thing to define because it means so many things to so many people. And I think, Kimberly, as you alluded, what's really helpful is to start thinking about these end-of-life issues way upstream before we might actually conceive of sort of more traditional palliative care. But I think the simple way of looking at palliative care is it's really a philosophy of care to address all fears of suffering and hopes and dreams of wishes for people that are facing serious illness or end-of-life situations. That's kind of one way to look at it. But the actual provision of palliative care is very dependent on where you are. So it's not the same one hospital to institution to agencies, and even hospices can have very different ways of providing palliative care. So hospice is a subset of palliative care. Palliative care is a much broader sort of context of care that really is centered in relationship-centered care and whole person-centered care and team approach to care like we have on the screen today.
Absolutely. That's thank you for defining that. And I want, Barbara, you and Gabby, Barbara, you've been in this field for 20 plus years. Gabby, you've been almost a decade in this field. And so I would love for you guys to, bat back and forth of what hospice means, because hospice to me, I love hospice. And Gabby, you now are a hospice nurse practicing at the bedside. And Barbara, you have been educating hospice nurses as well as people like me for decades. So Barbara, go first. Like what does hospice mean to you?
Hospice to me means that we are more than our physical bodies, and that just because we can't heal the physical body doesn't mean there isn't healing to be done. Hospice heals the emotional, the mental, the spiritual parts of the person. Our medical model is really focused on the physical, where hospice is really focused on the whole person. And I think that's what makes it stand out. And then add to that, hospice takes care of the family and primary care people as well as the patient. And I think those two aspects are what separates it from the medical model that most people are familiar with.
I love that explanation. Now, Gabby, there's a lot of myths about hospice. Like people, they come on and they talk a little bit about they have 24-hour nursing care. And even by saying that is true, but you are a practicing hospice nurse. And I want you to educate us on what hospice means to you, but can you help us a little bit with the myths at the bedside? Like there's really big misunderstandings when it comes to hospice care. So I'd love you to contribute a little bit of some of those myths so we can clarify it.
Absolutely. I think for me, one of the things that I say often is that hospice is not a diagnosis. It is a plan of care for the diagnosis. A lot of people see hospice as the death sentence. Now, the truth is, when someone does come on hospice, it does mean they have a terminal illness, but it's bigger than that. It's the type of care, and like both Gary and Barbara have said, it's a team effort to reduce symptoms, to provide comfort and support to both patient and family. And I think that one of people are so afraid of that word that they can't get past that. They see death. And I always find myself saying, but wait, there's more. I mean, you get a team of amazing people who can provide, have so many resources, first of all, right? And they provide this care that kind of helps you navigate the dying process. We can't change the outcome, but as I like to say, we can make the landing softer. You know, the one thing people always think, yes, you get 24-hour nurses. What that means is that you have a phone line that you can call 24/7, and you have people that can answer your questions. We can have nurses that come out. Some people think that we provide caregivers. We do not provide caregivers, but we have the resources to help you to find them. We have social work and spiritual care. We have volunteers, and we have home health aides that can provide a beautiful bath and bed. And I think what people don't get to really see is the team and the benefits that they bring for both patient and family. So I want to help people see that it's a plan of care. It's just reducing suffering. It's reducing any of the difficulties that happen at the end of life. And it's team oriented, which I love. And it's a lot more than people realize.
Dr. Gary, jump in.
Yeah, you know, it's the reason that a lot of us are drawn to work in hospice, actually, in palliative care, because of the team thing. You know, we sometimes call it a team sport, which doesn't really say it the best way, but really it's about the collaboration and knowing that we have the ability to be able to take care of the different areas of people's lives, you know, whether it's a psychosocial need or a physical need or relational need or, you know, social needs, those kinds of things. So it's actually one of the great pleasures and joys and fun things about hospice is really working with a team. And it's really to the benefit of patients and families.
Can I add something?
Please, Barbara.
I think hospice has the PR image that we take care of people who are dying. And I want to change that PR image to hospice helps people live the very best they can within the confines that their body and disease has put them in. And I think we need to concentrate and get across to the community that hospice is about living. And counteract that, well, you know, I don't want mom to come on hospice because that means she's going to die. And so it's about living the best you can. And we're experts in that. We can guide you to have this beautiful end of life experience by living.
And you know what else I feel that hospice has done in the past 40 years is that we have done crazy education. So much education. Barbara, you yourself do a lot of education. Why are we still having trouble with understanding what hospice is? It has nothing to do with that moment we call death. As everything living up to that. Why are we having still difficult times 40 years after we brought this to the United States? Please, everyone chime in. Barbara, you go first.
Well, and I don't know. I have spent 40 years trying to change that impression of hospice is about dying. I think it starts with our medical profession. I think it starts with physicians in educating their patients when it's time to introduce hospice, when it's time to introduce end-of-life care. I think our medical model is more focused on fixing, and we view end of life as a failure. And so it starts there. And I think as hospices, we've got to go to the community and do what we're doing today, which is educate the community so that the family or the patient, when given a life-threatening diagnosis, will feel comfortable in saying to their physician, what about hospice?
I love it. And it's amazing to see what individuals who are educated about choices and end of life, what they choose. It really is. But Dr. Gary, what do you think? Why are we still struggling? You represent internal medicine as well as you've been working in hospice and palliative care for 20 years. Actually, your colleagues still struggling to make and identify dying individuals. What is your perception and your viewpoint?
Well, I think Barbara had it just right. I would add, and this is a bit of a systemic explanation, is the Medicare hospice benefit is like an on and off switch. And so it's a big hill to climb for patients at times to feel that they're disengaging from one system and going into another, when in reality, it really is more of a continuum. And it's becoming more difficult now because some of the therapeutics that we have now, allow patients, particularly with cancer, to continue getting relatively non-toxic treatments for quite some time towards the end of their life, which then often will preclude a patient from coming on to hospice because they're still getting, what you might call disease-directed treatment. So I think there's a systemic part where there again is this on-off switch. And the requirement of a 6-month prognosis is a little bit drawn out of thin air. Of course, patients don't experience illness quite that way. They experience it as a continuum. But I think a lot of it is kind of what's been said before. One of the things that I have learned, and I've learned this from patients over and over and over again, is that the process of coming toward the end of life and dying is primarily a non-medical situation with maybe some medical features, particularly toward the end of life. And so when we focus on the medicine and we focus on trying to fix things, it really puts the focus away from the situation that patients and families are encountering. And I think that's part of the problem. There's a tremendous inertia to medical care, to intensive medical care in particular. So I think that's part of it. I do want to say that I wanted to say this at the beginning. What we've learned, I learned so much from Gabby, and how we kind of all stand on the shoulders of our mentors who have preceded us. I really feel like in this field, this is something where we learn way more from our patients than we actually teach them, and that one of the biggest challenges is remaining open to learning from our patients and families. And I feel like any kind of experience that I've accumulated, it's been, as being gifted from patients and families that have taught me how they navigate, serious illness and end of life.
I love that. And what scares me, and it is a fear, because I love hospice, and it's sometimes overregulated in my opinion, and not reimbursed to take care and have room to take care of the staff. And Gabby, you're working at a hospice, but you also are a death doula. And I would be remiss if I did not talk just briefly about what death doulas are doing in this industry, because it's so new. And as I traveled in my tour, some hospices and some communities are all that, yes, we have them, we're doing it. And then other people are scratching their head like, what is that? So tell me how you trained as a hospice nurse as well, but you're also certified as a death doula. And what is that bringing to this end of life field?
Well, Barbara and I have had this conversation. We really want to see it incorporated, right? Come together. And Gary and I have talked about it recently too, trying to find a way to implement that. As a hospice nurse, well, I think that hospice nurses are doulas. They maybe some of them don't have that training, but I think the process of sitting next to somebody's bedside and providing that care is that of the doula. The benefits of being a death doula, at least for me, is that we can linger a little longer. One of the things that I see in the work that we do now is that patients are brought onto our service just in the last, sometimes hours, days, maybe weeks. As a doula, we would be able to start with that patient from diagnosis, which could be months, which could help create like Barbara was saying, a better life during their dying process. And having more time allows us to help the family connect with them, help work through the process, help navigate, kind of set them up for for this process that could actually be far more beautiful. But we get them in a very short window of time, and it's very hard to do all of that magic and wonder, which I think that we love to do so much. And as a doula, I can do that. The other part of it that I love is the lingering after. A lot of times as a hospice nurse, someone takes their last breath. I call the time of death. I walk out the door. When that door closes, I feel that my connection has to close too. And it is one of the things I struggle with most of all, is having to walk out that door. As a doula, I can stay. I can reach out to the family. I can provide more comfort and support. And I am very drawn to that. I would like to have the opportunity to be sort of a death liaison, start a death choreographer, right? Like have the playlist, have the rituals, have the conversations, bring the families together. I'm very drawn to that. And that is what I see my role as a doula. I would like to incorporate that into the work that we do now.
Yeah, I think doulas are like, they add the color to a very dark subject. Dr. Gary, you were going to comment?
Well, I was going to say, I'm taking Gabby's doula class now, which is just fabulous.
Oh, and wow. Good.
Really, what Gabby is saying is, what I see, it's not, how to say it, very often our work is a balance of doing and being. And meaning that there's stuff to do. There's the choreography, there's the working with families to give them tools to be able to really care for their loved one. And there's also the aspect of it that's simply being present. And so the doula training is really, I think, about really merging those really well. So we understand when it's time to simply bear witness and be there and just be strong with the family. And when it's time to do stuff, because there is a lot of stuff that can be done that can really alleviate suffering. And I learned so much from Gabby. There's a lot of little tricks in the trade. We were talking about hospice hardware, as the toolkit, a little bit about what I thought this conversation was going to be about. What are the things at the bedside? There's stuff that can be done that we can impart to families, but there's also this aspect of it that I think is really beautiful in doula training, which is maintaining a steadfast presence, and sometimes that's really hard for hospice nurses because of really simply of staffing and timing and all of the stressful things that there are on healthcare workers.
Thank you. And what about, Barbara, go ahead.
When I started out in the 80s, before hospice Medicare, I basically was an end-of-life doula. That's what hospice nursing was. And our goal was to be with the family at the moment of death, because that was the moment that was most important for support for the family, because that's when they're most terrified. And so all of our education and our support led up to the moment of death. And then Medicare got into the picture and started micromanaging, and there was less and less time to be with the family and to be at the moment of death. And so I consider myself an end-of-life doula that happened to have some nursing knowledge. And so it excites me so much today to see the end-of-life doula coming forth, because we need them. We need that.
Totally need them.
To have the support in the hours to minutes before death and following death, because that will provide a foundation for how that family grieves forever.
I totally agree with you. Totally agree with you. And I do believe, because I'm such a huge fan and she has been my mentor my entire career in hospice, I believe the doulas have an opportunity to bring Dame Cicely Saunders' vision back to the original hospice movement. And that, to me, excites me beyond anything right now. And so, a lot of people ask me, are you going to be a death doula? And I said, no way, because I want to promote them. And I can't be one and promote them at the same time, because I want to be like bipartisan in this. Because I do believe that for the first time in my many years of hospice, we have a chance to really grow connection, presence, bearing witness once again. And I think the doulas are going to play a very vital role in that. But we're here. But I thank you for answering the death doula question, because I do think it's relative, and I think they're going to have a big impact. But we're here to talk about those difficult questions at the bedside when people are within the dying process. And let's just assume that I want hospice, so let's assume that we are in hospice care. And what I would like to do is really be blunt about some of these questions, because some of these hard questions or difficult questions, I hear families have a lot of, I guess, after reflection. And the first one is what I hear all the time is hospice is a death sentence. And I think, Dr. Gary, and Barbara too, I'm sure you've been in this field for decades. Why and how can we help people understand that hospice, like you said earlier, Barbara, is more about life than death? Why don't you take that, Barb?
Oh, okay. I think it goes back to education. 90% of our work is educating the family, the patient, the community on what end-of-life care is all about. The perception out there is that it's giving up. And it is, I just have to keep repeating and emphasizing, we will help you live the best you can. And so often someone's been told they can't be fixed, and they go home, they sit down in their favorite recliner, and they might as well have died that moment because they stopped living. And so we can come in and educate about pain management. That's a huge, huge area of confusion and misunderstanding. So we can help provide comfort and guidance and knowledge. Because when we talk about dying, fear permeates everything. And education neutralizes a lot of the fear. And that's our job.
Dr. Gary, we're in this time right now where we're hoping that a pandemic might be on the horizon of ending. But this has brought this death question to the forefront. And can we all admit that all four of us on this call, we are dying every day. And that's the sort of realization is while I was traveling the country is I saw hospice patients living fully. And those who were struggling, working full time and balancing all these other things, I saw living people actually dying a little bit every day. And so I think hospice patients can be really, really good teachers, and they're my teachers. But why is hospice all of a sudden just, in the histories, hospice equals death, which we're all dying. So I think hospice, like Barbara says, is about living your best life to the end. Dr. Gary, why are we still struggling with this?
Well, this isn't going to answer that question, I don't think, but I feel moved to say this, and it may sound a bit negative, but I do think that what I'm going to say comes from a mistake that I think is often made in the discussions coming up to hospice frequently by doctors, and I've learned this one over and over again. And it's important, absolutely, to explain what hospice is. It's really about about really stressing what's most important to patients and families and finding what their meaning structure is and what's going to be, the best quality of living. But what often happens early on is that the challenge of going through that process of accepting that one is in a situation where one may be approaching the end of life is not allowed to really progress in kind of a natural way. And so it's always a source of inquiry into what a patient is experiencing. If there's fear, it's important to understand what the fear is about. And it's not usually helpful, I think, initially to focus immediately on kind of the positive aspects of hospice
Sure.
before one is actually able to go through the process of confronting the reality of the situation and actually going through some grieving process of loss. Because really, in the process of dying, for many people, it's an accumulation of losses. And when we don't acknowledge those and don't really understand what those actually mean to the person, then I think we're moving too quickly to focus on something that looks rosy when, in fact, from the patient's perspective, they have to get there. And that's actually what patients have taught me. I think one of the most difficult things in the hospital setting is to see these decisions come to really quickly without a patient and family being able to go through the process that it takes to kind of climb over that hill. So I hope that's clear, but I think it really has to do with the sensitivity and the time that it takes to be able to engage in these discussions that lead up to a hospice situation, so that when they get there, they have a much better understanding of what they're going to be receiving and where they've been.
I think, Gabby, talk to me about this. Here I am. I'm on the eve of turning 50, and I've been in this field, and I know what I need to live well as die well. But when is the right time to start peeling back the onions and the layers that we need to really think about this? Just because you think about end of life and prepare for it doesn't mean you're going to die, right?
Right.
That face. Oh my gosh. Well, when should we begin these conversations?
Are you asking me?
Yeah.
Okay, so I think we should start talking about it from day one. The day we are born, when we can start talking, let's talk about the fact that one day we're going to die. We are all going to die, right? If we lived the life right this moment as though we're going to die, then we would live a better life, I think. I would like to think that. I would also like to think that if we have communication and conversations with our families, with our children, with our friends, with our loved ones about death and dying, if we weren't so afraid to talk about it, if we made it a topic of conversation as comfortable as talking about a new pair of shoes you just bought, right? It's just that easy to talk about. We wouldn't be so afraid. And then when you're given a diagnosis, right, and it's going to be terminal, like Gary said, and I'm probably translating this differently, so correct me if I'm wrong, but a person has to accept the fact that they have a diagnosis before they can accept a hospice care plan. So you have to be able to kind of absorb what's going on with you. After that, then I think that you can understand and appreciate the benefits of being on hospice. But if you talk about this freely, no matter what, whether you're healthy or not, and you get that conversation started, it would make those difficult conversations a little less difficult at the time you need them the most. I think we need to talk about it. I think that's what we're doing right now. We are changing this culture to be a little bit more death positive. Not that we're supporting death. We're not on some sort of cheerleading squad that's saying, go death. What we're saying is that,
Lemmings to the sea.
so what we're saying is that it's inevitable. And we can change our conversation to make it a little more supportive and proactive, and we can help one another walk through it. It's like a big secret. Everyone's, don't talk about death. Don't tell them they're dying. Wait a minute. Let's talk.
I love when you're on an airplane and someone's like, so what do you do? And you're like, hospice. And they're like, oh, the shoulders drop. They're like, you're an angel. And I'm like, no, man, I've learned so much more from patients and families than I have ever provided them. We use words, and because I really want to get in to some specific questions about really what families are struggling with when they have someone on hospice care. And, one of the questions and the terminologies that I believe scares a lot of people is that dying process, because maybe this is the first experience they're having. And we use words like death rattle. And Barbara, what is that? Because that seems very freaking scary to me.
It's just fluid accumulating in the lungs, really. And I personally think it depends upon how hydrated or dehydrated a person is how much congestion is going to be in the lungs. But if we take this opportunity to educate our families into what they're seeing and why, what I like to equate it to is dad's like a little chicken that's working really, really hard to get out of his shell of a body, and nothing works right. Everything is shutting down. And so the kidneys aren't pulling the fluid out, and the fluid is just sitting in the body, and he's breathing through a lot of that fluid. And that's why it sounds so loud and scary. But this is part of the way people die. And I think our biggest problem is that we don't have any role models. All we've got is television and the movies. And people don't die like they die on television or the movies. And so it is our job as end-of-life educators to teach them and show them that mom's doing what she's supposed to be doing. Nothing pathological is happening here. This is how you die. And you know what? She's doing a good job. She is letting go of her body in a really good way. And it's scary for us to watch it. But once we know that what's happening is normal and she's just working hard to get out of her body, and that's what we're seeing, I think that neutralizes a lot of the fear of hearing the death rattle and all the other things that go with those hours to minutes before death.
You know, I love that explanation. And the one word that popped out was normal. This is very normal. And I feel that when we've not been at the bedside with patients and families and they hear what we call a death rattle, it's frightening for us on the outside. And by this education we're even doing today, if we continue to educate people saying this is a normal way that individuals are dying. The other thing, and Dr. Gary, I'm going to direct this question with you, is a lot of people at end of life, especially caregivers, they want their loved ones to eat and drink. And what's so hard is because they don't want to starve their loved ones. So are we doing that? You know, when the body shuts down, talk to me about that process, because, you know, people want to feed and make sure mom and dad or whoever's dying has water. What is your opinion of that in that stage of the dying process?
Well, you know, feeding is nourishment. And we've spent most of our lives, you know, being nourished by food and having other people nourish us by food. So it can be really hard to let go of that. And then, like you say, there's the thought that, well, not eating and drinking, well, the person was going to die of dehydration or starvation. And so, like Barbara's saying, a lot of this is just really about education and about explaining what the natural process of illness is. And you know, if it's pointed out to many families that their loved one isn't actually hungry or thirsty, that maybe they just want to wet their whistle a little bit and have a little moisture in the mouth, those kinds of things, you know, it's relatively easy to, I think, educate people that it's not comfortable for people to be fed when they're not hungry, and it's not useful. And then really coming back to the explanation of what is the elephant in the room. Often the elephant is the illness that the patient has, which is really, you know, causing a lot of the symptoms. And then we often will explain that dehydration can often be a protective, you know, a body's protective mechanism in a way. People often feel comforted in a more dehydrated state, like Barbara is saying, that there's less fluid to accumulate in the lungs or the abdomen or where it might be. So it's constant education about that. In terms of terminal, you know, the death rattle, like Gabby and I were shaking our heads, we just have to so often educate families not to use that term,
Right.
and actually I tend to shy away from even the use of terminal, because it has I think for me, it has a kind of a pejorative clinical aspect to it, and talk more about actually what's really happening about the dying process. But with terminal secretions, they're often very noisy, but we educate people that they're not causing difficulty breathing, they're not obstructing breathing, they're not, it is a natural process. And then if it looks like there's a lot of suffering associated with it, then we have to really understand whether it's the patient that's suffering or it's the family looking at the patient who's suffering. And that actually is one of the main points, I think, in end of life care, is trying to really tease out that relationship. Because very often, like in a hospice house, we'll have a patient that's basically been essentially comatose for a few days and don't look at all like they're in distress, but the family are looking at them and going, they're suffering terribly, they'd never want to go on this way. And then really it's about addressing the family's suffering and their loss. And then it's not about giving the patient atropine or something like that. It's really about supporting the family through the grieving and their anticipatory grieving.
Well, and Gabby, you at the bedside as a hospice nurse, we caregivers, when we see our loved ones, we want to fix it. We want to make it all better. And I think that's a very human experience. And that's why having someone like you, a doula at the bedside, can help and provide permission that this is normal. What are some of your experiences? Because I hear, is it painful to die? And since I've never done it, I don't know, but I need the clinical aspects of an explanation. Is it painful to die?
Well, I'm going to be coming from a different perspective. I tend to talk like a 5-year-old sometimes when I explain things. I'm ooey gooey, soft and mushy. Is it painful to die? I think that it can be uncomfortable. I think that there is some pain associated with what somebody might be experiencing based on their diagnosis. But I would like to think, I think Gary can probably answer this from a more medical perspective, but what I like to think is that when it comes down to those last breaths, I do not think they are in pain.
And I believe that's why it's so important to have, and hospice individuals and hospice teams, I believe they're pain experts. And so there are ways to make the patient a little bit more comfortable. And here I'm going to use the M word now, morphine, which scares people to death, mostly. So Barbara, help us understand what morphine does for someone who's actively dying. And before you even go into that, what is dying and what is actively dying? What is that? What's the difference?
Well, there's a process to dying from disease or old age. And it's gradual, and where fast death doesn't have a process, gradual death has a process. And most people on hospice are dying a gradual death. And everyone plays part of this in this process. Some people will do everything, some people will do none, but most people will do some. And it's broken down into months before death, weeks before death, days and hours before death. And in this process, it's showing us the normal way that the body is programmed to die. Okay. Our body has been dying in the same way since it was created. It is how we deal with how the body is dying that has changed over eons of time. So in the days to hours before death, everything in the body is shutting down. Nothing works right. The blood isn't circulating properly. And if pain was part of the disease process, then hospices or end-of-life belief is that you medicate that pain, you treat the pain until the very last breath. But dying itself is not painful. It is disease that causes pain. So if their disease had no pain, and there's a lot of diseases that don't have physical pain, then just because they are days to hours before death doesn't mean that now they're in pain. What you're watching as you see that body struggling to release itself from this world. And I'm back to education. Mm-hmm. You've got to educate the family as to whether this dying, normal, natural dying process is related to pain or not. And that goes into the history. What I get a lot of, and I'm going to just jump into this, is I get a lot of mail from families saying, hospice gave mom morphine and they killed her.
Right.
They gave her morphine and, 2 hours later she was dead. It's their fault. Well, if mom died 2 hours after she was given morphine, or any medicine for that matter, that medicine is still wherever they put it in the first place. If it was in the mouth, if it was in the rectum, wherever, because nothing works right. It's not circulated. So again, I'm going to sound like a broken record. We have to educate about narcotics and about what happens in those days to hours before death.
So, Dr. Gary, in your opinion, what does morphine at the end of life do? I've heard it relaxes bodies to breathe better. So talk to me a little bit about what does morphine do for the body, but also, how do we know if our loved one is suffering or just going through that dying process? I think there might be two different things there.
Well, so let me go back, if I can, to the question that you asked before, which is dying painful? Because I think the question really is very deep, because it's extremely deep. It's a existential, psycho-spiritual, question, really. It's like, and particularly for patients that aren't able to tell us what they're experiencing, is what is happening to this consciousness in this person at this point in time? And I think that's a profound mystery. And I'm really humbled by how challenging it is to know what's actually happening toward the very end of life for patients that are not communicating with us. Are they suffering? Are they in pain? Are they hearing us? We have sort of classical teachings in hospice and palliative care that patients, hearing is the last sense to go. And we do that, I think, a lot because we don't know, but also to encourage families and loved ones to express themselves to the patient. I think it's extremely important. What is actually occurring in the person's consciousness, I think, is a vast mystery. And so what these medicines are doing at this point of the dying process, I think, like Barbara is saying, it's hard to know whether they're doing anything. It's hard to know whether they're actually treating a target symptom. But with respect to morphine's a very powerful and useful medication to treat pain, both acute pain and chronic pain. It's very helpful for patients who have very disabling shortness of breath. In particular, we have a patient at our hospice house now, a young woman who is, she's essentially dying of respiratory failure, and it's very hard for the family to watch. It's very hard for her to experience, but she doesn't want to have the sedative properties attributed to it. So she wants to try to remain awake for as long as she can for her 3 children. So she's choosing how much suffering she's willing to endure. But the morphine, like I was telling her last night, could help her. It's her choice how much she wishes to take. Once she becomes unconscious or more unconscious, it's going to be on our shoulders and the family shoulders to try and determine what degree of suffering she's having. And I think it's really challenging, actually. One of the things I did want to say about what Barbara was talking about was, and this is kind of how I've learned about the very end of life. There's people who take the high road and the low road. That's kind of a simple way of looking at it. Most people take the high road. They descend through the dying process with a little bit of midwifery from us, a little bit of doula, a little bit of medicine, maybe not, Maybe they don't have pain. Maybe they're just declining as the body systems shut down and apoptosis happens, and then they pass away with relative peace. There's a small percentage of patients that have a lot of symptoms at the end of life. Those are the patients where the medical interventions can be useful. And then we have to be really discerning about whether they're actually being useful or not. And the last thing I would say about this is, because I think it's important to be really pragmatic about this, we don't know a lot about how these medications work at the very end of life, and patients aren't able to tell us their experience because you can't really study it very well. So we have to use all of our senses. That's actually one of the things that the doula training does really well. And like Gabby and I were talking before, really depending on the family's perception of the patient, knowing that it may be colored by their own experience, but they know this patient's nuances of facial expressions, nuances of behavior way better than any of us will ever know. They've lived, the patient I have in the hospice house now, her family has lived 4 years with incredible amounts of medical intervention, some of which they've been doing themselves. So they know their loved one better than we will ever know them for the 1 or 2 days or weeks that we'll have that patient. So I think, again, to summarize, that is a vast mystery in what's happening at the end of life. And we have to be really attentive using all of our senses and the benefit of the family's understanding to be able to treat patients well. Morphine is absolutely a good drug to use in the right circumstances.
Well, Gabby, what do you do at the bedside to engage the family's involvement within the dying process, especially when it comes to, is it okay if I say this? You know, I remember my grandmother over my grandfather, and she's yelling at him like, "Don't you leave me! Don't you leave me!" And I'm like, "Holy cat!" I mean, do they hear her? You know, it's like, how do we educate family on sharing their emotions, but also respecting the process of this person, like Barbara said earlier, you know, birthing themselves into death, laboring. What are some of your recommendations?
So I tell the truth. I don't mince words. I used to, when I first started, I thought I had to say things softer. I thought I had to sugarcoat things a little bit because I was afraid that I would scare them or hurt them somehow. And I certainly don't say things in a hurtful or scary way, but I tell the truth. And like with regards to medications, first of all, we've all said this a million times, and it's about education. If you can remove fear, your families will have a calmer demeanor. They will feel less afraid. Medications, I'm a big fan of seeing what else we could do before using them. You know, most people know that about me, but I do believe in them, and I believe that they work, and I believe that they are a necessary part of what we do at the end of life. What I try to tell families is I'm going to go back to the morphine first, because this is one of the things that I say. Any of the medications, but let's say morphine, you know, is this going to kill him? Well, what I say, because what I want is that family member to everything I do at the bedside is imagining what their takeaway will be after those last breaths have been taken. How are they going to feel after their loved one has died? I want to make sure, and maybe that's the doula in me as well, is I'm always thinking about that. And so as far as medication, my go-to thing is to say, here's the thing. The amount that we give is not going to end his life. His diagnosis is going to end his life. Could he die after taking this? Yes. But chances are it's because that medication put him in such a calm state that he succumbed what he was going through, and he gave into it and he died. Did the medication kill him? Probably not. I would say no. But I try to tell that family, don't be afraid. We are not going to give him something to kill him. We are going to give him something to help him relax and give in to what the process is already let out for him. I tell the truth. If I see them, the death rattle, I simply tell exactly what you guys say, but I say it's normal. This is part of the process. We're the ones that have a reaction to it. It's okay. He's okay. We just need to know that this is part of the process. And anything that is going on at that bedside, I just tell them the truth. And I think that if it's moments before, you know, I'll stop for a moment and I'll pause and I'll look at that wife who is about to say goodbye to her husband of 70 years and I'll say, He's about to die. Do you have anything else you want to say to him? He hears you. I believe with every ounce of my being that he hears you. This is your time. Tell him everything. Give him a takeaway, something that when he takes that last breath, he gets to take that with him. And so I create this moment that after that last breath is taken, she said her last words. She felt peace with the choices that were made by the hospice team as well as herself, and that everybody worked collaboratively to make sure that he had a soft landing. So I believe that the thing that we need to do is tell the truth. The absolute truth.
Gabby, I'm in love with you. Will you be my hospice nurse?
Yeah.
I'm telling you, you just gave me chills, and I'm speechless. I just think the families that you serve must be, wow, really, really impressed with the spirit that you walk in.
I learned from the best. I've got
right?
mentor, I've got my teacher.
Yeah, and even Gabby, you and I talk about how Barbara is such a teacher to us throughout our journey as well.
Let me, Kimberly.
Sure, please.
Yeah, absolutely. I mean, I don't know that I know someone that does this kind of deep work better than Gabby. I've learned so much from her, and it's also beautiful to see it even maturing even more. There's two things there that are really important. One is she's masterful at empowering families to go through this process, which is a really key piece of this. And also at the same time, she's giving shots over the bow about what to expect. She's educating about the landscape, which is a part that I think is really underappreciated. One of the things that we've learned on the backs of all of our patients and families is the landscape of dying. And that's the experience from all of those families that we can bring to bear on this one individual patient and family. And so she does that really well. And so these shots over the bow, I call them, because I think it's really helpful to do that, to prepare families what might be happening in the next minute or hour or day. She does that really well. And I think what it does is it does lend to that softer landing, and it enables that to happen.
Like knowledge is power. And Barbara, you Gone From My Sight is a book that you have really educated people on that process. And my family has used it through my grandfather's death. Talk to me, Barbara, about some of that common dying process that you have found and have wrote about so eloquently in Gone From My Sight. Us in hospice care call it the little blue book. But talk to us a little bit about that, because knowledge is power. And knowledge does lessen fear. So talk to us a little bit about that.
Okay. I'm going to say before I start, I see Gabby's work and at the bedside, the professional is like the conductor and is orchestrating and trying to get everyone at the bedside to be in harmony with each other as they support, and you're guiding this person through their final experience. And it was Gabby, that was a beautiful explanation of how to be that conductor. Okay. Gone From My Sight. I started as a hospice nurse, primary care nurse, in the early 80s, at a time when we had, as a society, we didn't even address people that were dying. If someone was dying, we stuck them at the end of the hospital corridor, and nobody went down there, and you eventually found the person dead. I mean, that was how we dealt with it. So no one really knew that there was a process to dying from disease or old age. It took me being at the bedside, and we had patients for 1 year. I had Charles for 2 years. He's still in my heart. But we had them longer. And so being with these people as they were dying, I noticed they were all doing the same thing. And I came to realize there's only two ways to die. You either die fast, getting hit by a truck, or having a heart attack, or you develop a disease, and that disease has a process that begins months before death actually happens. And it wasn't medically oriented, which is what really surprised me, is you have to look beyond the medical and the disease. I don't even have to know what the disease is, and neither do you. You look for three things: eating, sleeping, and withdrawal or interaction with the world around you. Those three things start happening months before death. And then it's all on a continuum, and you watch this. And then there are other changes that occur that say a person has weeks to live, 1 to 3 weeks. I call it labor. And then there are death is imminent, you're talking minutes to hours. Well, in recognizing that, one night I was on an on-call dying, I'm scared family call. Mom's in the bedroom and I'm with the family, and we're talking about what I've said, the process. And one of the daughters was taking notes. And I thought, oh, don't need this. What's wrong with this picture? And I went home that weekend and wrote "Gone from my sight," which is what I wanted to teach families, so that knowledge reduces fear. I have to say it again, so that they could see that nothing bad, nothing pathological was happening, that this is how people die. And that's where that came from. And it's just taken on a life of its own, because it's short, it's simple, 5th grade level, non-medical.
We're closing our time here today, but one of the questions coming from families and patients that haunt me, almost wake me from a deep sleep, is I wish I would have known about hospice sooner. And I feel that until I take my last breath, I want that question to disappear from this field. And I guess let's take an opportunity that everyone has a chance to respond to that. How do we take that away? How do we increase people to engage in hospice sooner? Why is it that it's always 2020? What is some of your advice? And Gabby, we'll start with you. How do we get individuals to understand what hospice does, and how and when do people need to say, my mom is actively dying? Just like Barbara said, here's 3 things. And I feel like if we had those 3 things, but we're so close to the picture, sometimes we don't see the full painting. And so each of you, please help me. How do we bridge this gap of education for people to lean into hospice when they need it?
The hospice order is given when there is an assumed 6 months or left to live. And I think people think that they have to wait until this person is on his deathbed to start it, because that's when it's supposed to really start, even though they can get this hospice order at 6 months. If we could take on our patients earlier on, we could change the experience that both the patient and the family has. I want people to understand that it could be kinder. It could be less of a struggle if they started with us sooner. And it's because of what we are trained to do. We understand this process. Of course, we're learning every day, and no one really dies the same. And there's so much that we're constantly learning, but we do have the tools. Take advantage of us. We have such a wide variety of things that we can offer you to help to ensure that that you're not going through this alone. So what I would like to do is keep this conversation going, get people to talk about it, help people to understand that if they start with us sooner, it doesn't mean this person is going to die sooner because they've suddenly opted to start hospice. It means that that they're going to take our hand when we offer it to them, and they are not doing it alone.
I love that. What about you, Dr. Gary?
Well, I'm afraid my answers are maybe a little systemic or academic. One is certainly about education. To have people come on hospice sooner, a lot of it is about educating clinicians and doctors in particular about the benefits and trying to come away a bit from the fix-it, the fix-it culture of medicine, and to really encounter patients where they are without giving them false hope. That oftentimes will help folks make the transition. I do think that there's a systemic issue, and that really until we start taking better care of our elders, particularly our frail elders, with a more comprehensive system of long-term care and palliative care that's integrated rather than fragmented, it's going to be a challenge to get people into hospice in a timely manner, because hospice now actually gets used in a way as long-term care light, if you will, which gets hospices in trouble. And so we really need, I think, systemic change in order to really provide the kind of comprehensive end-of-life care that I think we're all talking about today.
I love that. And Barbara, talk to me. I know you have some opinions about this because you and I have talked for hours about this. How can we change this?
I've been trying for 40 years to change this, and I don't feel I've made very much progress. I certainly agree wholeheartedly with Gabby and Dr. Gary. And the only thing that I can add, which we've already addressed, is the community. We're not having a lot of success with the medical establishment. And I think that's because the emphasis is on fixing instead of recognizing that everybody dies, and that in itself is an art form in how we can support and guide people at end of life. So we have to go to the community, and that senior citizen groups, church, Sunday school groups. We've got to newspaper articles. We've got to educate, and hope that we're heard, because we're not getting the support, really, I hate to say that, from the medical community as far as making appropriate referrals.
So we've been talking here on our new platform at the bedside, and I know that we have answered some questions that have come up at the bedside when someone is at their end of life. But I know you who are listening might have additional questions. And Gabby, why don't you tell us, if someone is watching this, if they have a question that we've not covered, how do we engage them to send those questions so that you, Dr. Gary, and Barbara can collectively come together and answer? Because that's our goal here at the Bedside platform, is that we want to answer questions way before you need that final answer, or before you even need hospice care. We want to educate the community members to direct their care. So help us in how we're going to invite those who are watching to contribute with questions.
Well, I have an idea, and I'll see if Gary and Barbara are on point. My email is thehospiceheart@gmail.com. And if there are questions that you have, please send them there. And then I'll share them with Gary and with Barbara, and collaboratively we will come up with some answers. And then we could either have another series and continue this, or we can answer them publicly on our social media. Barbara, you and I can do that, so that we can, my hope is that we can create a space for people to ask the questions, so the questions get asked. So if you want to send them to my email, Barbara, if you want to have them send them to you, I want people to start feeling safe and comfortable asking the questions. I'd be happy to answer more.
Give me that email address one more time.
It's thehospiceheart@gmail.com.
thehospiceheart@gmail.com. And this is what we're trying to do, is make sure that you are prepared with the questions. I recently just had a phone call this morning about a family member struggling with their mom, wanting to enact how she wants to face her own end of life. And sometimes you just need to ask the question because you most likely know the answer, but you just need confirmation of, hey, am I doing this? Am I doing this right? And sometimes the way you're doing it is totally the right way. You just need someone to support you and be the cheerleader. I can't tell you how much I have loved this at the bedside chat with you today, Barbara Karnes. You know how I feel about you. And I think you're just amazing. Gabby, you and I, my sidekick here, we really want to continue these conversations, calling it At the Bedside. So even if you would like to email Gabby and say, hey, this was a great conversation, and make suggestions of what other conversations we need to bring right here to you at the bedside. And Dr. Gary, I can't tell you how much I respect you. I love what you're talking about when it comes to the death doula movement and how they can impact, even make hospice even greater. What you three individuals do is you radically change how people face end of life on a daily basis. And I am personally honored to know each and every one of you. Thank you for joining us today. Any last words?
No, this is awesome. I say we just keep collaborating and start talking about it in a way that makes everyone feel comfortable. It's hard. Death is hard.
Yes. And the more we talk about it, I believe the better we will all live well as die well. Barbara, Dr. Gary, Gabby, thank you for joining me. This is At the Bedside, and I'm Kimberly Paul, and I host Death by Design podcast, but we're always interested in having new conversations, and I hope you enjoyed this conversation at the bedside.
Thank you.
Thank you.